They'll wake you up. Good morning. As Steve said, my name is Dr. Trent Proffitt, and before you decide to give anybody your attention, I think it's important that you understand people's biases. Came from Dallas, was the medical director of a wound care clinic there for 8 or 9 years, and I'm one of those people that loves wounds. Steve Hanau and Dr. Wilkerson, we all trained sort of in the same environment, and they like wounds, but I love wounds. And so you can tell the difference between a wound care lover and somebody that treats them because they enjoy it. Perfect example, this week I saw a gentleman with foot gangrene, and he also had penile gangrene. And I would tell Steve and Rick, listen to what I saw. And I was horrified yet excited because you never really get to see that. And they were kind enough to smile and nod, and that's sort of how I'm outcast in this trivascular trifecta. But anyway, so today I will fight off my urge to talk about treatment and things, and we're just going to try to focus on that wound. Why is it there? What is it? And that's incredibly important because, as Steve said, the incidence of primary amputations, not only around the country, but especially in this environment, is alarmingly high. That's like having a patient come in with exertional angina and they never get a cardiac cath and they just end up dying. It is unacceptable in most situations. Now, granted, we see end stage sometimes, and you see somebody who does not ambulate and their foot is not salvageable at that point. So anyway, that's what we're trying to avoid. So anybody that likes Clint Eastwood knows the good, the bad, and the ugly, and that's sort of what I want to talk about. We're going to talk about venous ulcers, we're going to talk about arterial ulcers, and mixed ulcers, which is the ugly. Leg ulcers, again, these are generalizations, okay? If somebody wants to grab me later and say, well, you didn't mention pyoderma, I get it, but we're trying to cover the breadth of everything. Lymphedema is one of the more common ones, and in my limited experience, I will tell you that lymphedema is a trash can term where doctors throw swelling into this and they call it lymphedema. That's not really lymphedema. The easiest way to tell is, do their toes look like little sausages shoved into a can? That's one of the hallmarks of lymphedema, and then the question is it primary or secondary? So kidney failure, hypertension, vasculitis. Vasculitis sort of is another trash can term in my opinion. If we're not talking about an immunologically mediated thing, then we're not really talking about vasculitis. You'll occasionally hear about the marginal ulcers from wounds, rare, infection obviously. And when I got done with my training about 15 years ago, we talked about the majority of diabetic foot ulcers were neuropathic, and that was so true back then. But actually now, current studies are suggesting that and this is a new term, neuroischemic ulcer is more prominent than the non-neuroischemic ulcer, meaning our incidence of peripheral arterial disease and the complications from these wounds incidence is going up. So the question is really, are they mostly neuropathic now? And some of the newer studies suggest no, they are neuropathic and ischemic. That is a bad actor. Again, generalizations, what we sort of accept. Venous ulcers are on the medial aspect of the lower leg and foot, or ankle, should I say. The further you go down the leg, the higher the pressure. And that's one of the themes we're going to talk about today, is pressure. It's all about pressure gradients here. Arterial ulcers tend to be on the foot, but they also can be over bony prominences in the pretibial area. So we're talking about how do you identify what you're seeing, when is it time to call for help, when is it time to call the National Guard, or can I just deal with this in my office and watch it get better? And it's sort of common sense. The further you go away from the groin, typically the worse the perfusion is, especially in this diabetic population, who typically has disease from the knee down. When I got here at New Mexico Heart Institute, they use the term venous insufficiency. And Steve and Rick and I's mentor, somewhere along the line, probably threatened to fire us if we use the term insufficiency. So we use the term venous hypertension, because that's what it's about. And we'll talk about the pressure gradients here. And a lot of you are going to say, well, why do I care? And I want to hopefully try to get you to care about these numbers. And when people think of swelling, they oftentimes think about it directly related to venous hypertension, and those are not the same thing. Believe it or not, when we're doing our interventions, we sometimes will intentionally cause a little bit more swelling to reduce their pressure. And I won't dig too deeply into that, but those are not the same thing. You can still have massive venous hypertension without having any swelling. Venous return, related to gravity, breathing, and muscle pump function. So if you think about that, you think about our obese population, you think about our patients with obstructive sleep apnea, and you think about our wheelchair-bound patients. All three systems have gone awry, and I'll talk a little bit more about that. So when we talk about venous hypertension, venous ulcerations, we talk about why is the pressure elevated? How is the pressure getting there? And if you think about, and I've got some diagrams coming up, you think about the venous system like the deep, the superficial, and then the steps on the ladder and the perforators, these pressures are significant. And we're not talking about 15, 20 millimeters of mercury, we're talking about huge numbers. So when you're sitting there in your office looking at these patients and they have an ulcer on their medial leg, is it 80, 90% of that's really venous disease, okay? You have the outliers, I understand, but we're talking about how does the pressure get there. Not to dig too deep into the pathophysiology, but this is stuff that I think is important to understand. All the theories of venous ulceration talk about increased pressure. And one of those theories means that you have more capillary distension, there's more fibrinogen deposition, and now your diffusion gradient from the oxygen is now getting more and more, and you add swelling on top of that, we're talking about a relatively ischemic wound. So venous hypertension, and now you're introducing a localized ischemia. One of the other theories is that the graded pressure causes endothelial damage, white blood cell retention, the proteolytic enzymes, and free radicals. That, y'all probably see the hemosiderin staining, the brown ankles, every day. If you go to the mall, you're going to see it every day. How does that pressure get there? It doesn't come from the deep system usually, by the way. It is not diabetes related. It is pressure. And so what happens is you have some serum leak out of those veins that have increased pressure, and your white blood cells attack it because they know it's not supposed to be there. They chew up the red blood cells and dump out the hemoglobin and iron. That's where the staining comes in. And as that process continues over time, that's when you see lipodermatosclerosis, which my scribe hates that I say that word almost every day in clinic. And you'll see the 400-pound patient come in with ankles this big. And they say, well, doc, I'm not swollen. Scar tissue can't swell. As that process of the elevated pressure goes on, that becomes just circumferential scar tissue. So their upper calf is this big, their ankle's this big, and they say, I don't swell. And now once you destroy the skin and tissue, now their lymphedema gets worse. So it becomes a slippery slope. One of the other common denominators that we talk about in the pathophysiology is the shear force. And I'll show you a diagram in a second where we're talking about the perforators coming from the deep to the superficial system. So in a normal person that has normal functioning valves and stuff, if I was to take a little needle and put it in your perforator and ask you to stand there and take a step, your pressure should be around 50. All right, that's for everything working well. The perforators either have valves or they're shaped like a ZZ top Z. So when you take a step, it shears that perforator shut so that pressure is not coming from the deep to the superficial system. If you take somebody who's of, let's say, 5'10", their perforators don't work, you put a needle in that perforator and ask them to take a step, that pressure can be 200. That's why when those patients come into the emergency room bleeding all over the place and they tell the doc, it was shooting across the room. You know, the doc sees them, they're laying down, it's not bleeding. It's not arterial, it wasn't shooting anywhere, the hysteria. It was shooting across the room. But it wasn't shooting with a pulse, it was shooting every time they said, oh my God, they increase their intrathoracic pressure, that pressure is transmitted downstream, and it shoots. So again, we're talking about significant pressure gradients here. I think you all have seen this. You're looking at hemosiderin staining, you're looking at venous ulceration, you're looking at lipid hermannosclerosis. In the area which is most prone to it is called the Gators region. It is the medial distal ankle, and it is where the most pressure is transmitted. It tends to be where the first perforator is. And if your greater saphenous vein, short saphenous, if those aren't working, that pressure is primarily going to be transmitted down the leg. You can have venous ulcers in the lateral leg, depending upon what your perforators look like. But the reason people get it on their medial aspect is because that's where most of the superficial veins and the perforators come off. Sort of makes sense once you conceptualize that. This diagram shows normal venous flow patterns. The flow pattern is from superficial to deep, so that your muscles can squeeze those veins when you take a step, and the blood moves up to the next rung on the ladder, the valve slams shut, and it moves up like this. Okay, the taller you are, the harder time you have. This is where things have gone wrong. If the valves do not work, that pressure is transmitted down the superficial system or out the perforators, and there's that chronic inflammatory process going on. I was speaking to a physician the other day and saw a patient with venous ulceration, and it was a nursing home patient that spent a lot of time in a wheelchair, but they had a big venous ulcer, been there for 3 years. It hurt quite a bit. And his comment to me was, if they're not dependent, they don't need to be fixed. Well, I think that's sort of true. However, if we think about the way that blood gets out of the leg, breathing, muscle pump function, and gravity, think about a person sitting in a wheelchair. They're not using their muscle pump function. You can still have massive venous pressure from somebody just sitting there, especially our obese population, patients with COPD, et cetera, et cetera. So one of the things that we talk about that's so important is loss of muscle pump function. And you look at this diagram here and you see how that venule coming in there when the muscle squeezes is supposed to slam those valves shut. If you are not using your muscle pump function, not only are you going to be swollen, but your venous pressure is going to be through the roof. I'm in no way suggesting that patients who are bed-bound or wheelchair-bound need their veins fixed. I'm just suggesting, look at this diagram and tell me how somebody who's obese and has sleep apnea spends the majority of the time in the wheelchair. Tell me how they're supposed to get the blood out of the leg. It just doesn't work very well. So when y'all have seen millions of legs like this probably, so when we look at this, I tell my patients we're looking for boring ground. That's hemosiderin staining. Lots of people have it. Doesn't necessarily mean they need an intervention. Maybe the compression socks. But if you look by the malleolus and you see how red that is, there's a perforator right under there that's about 4 millimeters and generating massive amounts of pressure. And as I go out into the community and try to understand how things work as compared to Dallas, people in Dallas don't understand perforators, and they don't understand that they understand red means inflammation, but they don't understand there's a perforator right underneath there that puts the patient at risk of ulceration. All right, let's talk about arterial ulcers a little bit. Arterial ulcers tend to be on the foot. In general, on the foot, it's an arterial ulcer. One of the things when we see patients that everybody wants to know is, can they heal it? Because the amount of perfusion needed to keep somebody's foot attached is not very much. Maybe 30, 40%. The amount of perfusion required to heal a full thickness ulcer, maybe 70%. I'm assuming they're not getting HBO, by the way. So if they have ischemia, what is their level of ischemia, and can they heal their wound? And is it an acceptable amount of ischemia so that they can heal it, but it's just going to take long? One of the things that I see an alarming trend is the lawyers going after limb loss. The patient that comes in has been on Keflex for a month for a diabetic plantar foot ulcer. That is a dangerous situation, not only for the patient, but for the physician. Maybe a little toe ditzel or something you get by with Keflex and offload, etc. But the moral of the story is, if you think it's an arterial ulcer, you're looking at a limb-threatening process. That's time to call the National Guard and get people involved. We look at these wounds as a race between healing and infection. So yes, they may have granulation tissue, and in general, it takes good perfusion to develop granulation tissue, that beefy red tissue. But is it going to be fast enough? Are they going to show up with cellulitis of their foot, in 2 weeks? Sort of some of the characteristics of arterial ulcers, it's a punched out lesion. There's no granulation tissue. Typically, these things penetrate very deeply. You see the pallor, the dry skin, you see loss of hair. And I'll tell you this, when I got from Baltimore to Dallas, I thought everybody had peripheral arterial disease. Then I realized everybody wears cowboy boots, so they were just wearing all their hair off. So there's a learning curve with that. Yeah. The arterial ulcer pathophysiology is the ischemia of the capillary beds, endothelial dysfunction, neuropathy, and loss of their autoregulation. One of the things that one of my colleagues will be talking about is the angiosome concept. And that is, when I came out of fellowship, when Dr. Wilkerson came out of fellowship, we were told if there's a pulse in the foot, that's good enough. I'm not so sure that's true anymore, especially for heel ulcers. But they're going to talk to you about sort of how the foot's divided and supplied by different areas. One of the things that you see oftentimes with arterial ulcers is you're robbing Peter to pay Paul. If you have a heel ulcer, you have a midfoot ulcer, the arterioles around that ulcer are going to vasodilate, and it's going to steal the perfusion from the front of your foot. And now you may have a patient that comes in and keeps saying, my foot's kind of numb. Well, what do you mean? Well, I lay down at night, my foot gets numb. It's because they're shunting that little morsel of blood they still had going to the front of their foot to their heel. And so it can uncover those patients with ischemic respiratory. The ugly is the mixed arterial and venous ulcers, because you can't have it both ways with these. You tend to recognize them because they're over bony prominences, okay? They can be pretibial, they can be malleolar, etc. But, for example, the patient comes in and they have horrible hemocytic and lipomyelosclerosis, and now you tell them to elevate their leg, and now they can't sleep at night because their ischemic breast pain is worse. So then they start sleeping in their chair with their sleep apnea, and now their skin and tissue here is never getting a rest. That pressure is through the roof 24/7 for them. There's no interruption like when we lay down in our flat bed, presumably. You can hear our ulcers and veins go, oh, thank God, because that pressure goes way down. Doesn't happen in these patients. So 15 to 25%, depending upon what you're going to call an abnormal ABI. These ulcers are mixed ulcers. And that is based upon people that they have measured with an ABI. Oh, by the way, an ABI is wrong about 25-30% of the time nationally. In New Mexico, I mean, some of my partners hardly even order these because they're so unreliable. There's so much medial calcinosis going on, the ABIs are falsely elevated. And so it's kind of like the Homan sign. I used to teach my residents and medical students, why would you even do a Homan sign? It's wrong 50% of the time. Why would you even do that? Why would you order a test to evaluate limb salvage if you have a 25% chance of being wrong? I'm not suggesting you don't order them. I'm just suggesting we also look at the waveforms and all that other sort of dorky vascular surgery stuff that we look at. If you think you have a mixed ulcer, you have to be very careful with compressing them. You can't just throw an ACE wrap and Coban on these patients and wrap them up tight. It doesn't work that way. You're going to make that area around the ulcer more ischemic. They don't have the perfusion to heal it. They may alarm you by saying they have ischemic breast pain. One of the more complicated ulcers that we see is on the medial foot, just distal to the malleolus. And one of the reasons that is such a difficult wound is we talked about the flow in the leg is from the superficial to the deep. The flow in the foot is from the deep to the superficial. And you can have perforators below the malleolus, and that is a really difficult wound to heal. Because, again, you're on the foot, there's probably a level of ischemia sort of some slides to show what these mixed ulcers look like. Over the bony prominences. You've got granulation tissue on this one, but it's kind of anemic looking. All right, in summary, medial leg, think venous ulcers. Foot, think arterial. Bony prominences in the lower leg, think mixed ulcers, the ugly, okay? We'll take questions afterwards for our panel discussion. Anyway, thank you all for coming today and inviting me.